Welcome back to the deep dive. Today we are putting on our scrubs, grabbing our stethoscopes, and stepping directly onto the clinical floor.
Right onto the floor.
Yeah, we're looking at a stack of lecture materials, slides, and, notes for the NUR112 module on vital signs. And I have to be honest with you,
Okay.
when I first saw vital signs on the schedule, I had a moment of, really? I mean, come on. We all know how to read a thermometer. We know what a pulse is. It feels so basic. But looking through this stuff, it is incredibly clear that for a nurse, these are not just routine numbers you scribble in a box.
Oh, absolutely not.
Yeah.
That is, I think, the biggest misconception new students have.
Okay.
If you think about the human body as this highly complex, high-performance machine, which it is,
Right.
vital signs are your dashboard indicators. They're the check engine light, the oil pressure gauge, the temperature gauge, all rolled into one.
I like that.
And the difference between, say, a layperson taking a pulse and a nurse doing it is the difference between noticing a light is blinking and understanding why the engine is about to overheat and seize up.
Right. And that is our mission for this deep dive. We're going to move beyond just memorizing the normal ranges.
I will cover those, though.
Oh, for sure. But we really want to understand the physiology behind the 6 primary vital signs. So we're talking temperature, pulse, respirations, blood pressure, oxygen saturation, and pain.
And the key theme here, the thread that runs through every single one of these documents, is clinical judgment.
That's the buzzword.
It is. It's all about knowing when a number is just a number and when it is a massive red flag that requires you to, drop everything and intervene.
Okay, so before we even get the blood pressure cuff out, we need to make sure we're speaking the same language. One thing that jumped out at me immediately in these NUR 112 notes is the heavy emphasis on medical terminology.
Yeah.
It feels a bit like learning a secret code.
It really is a code, but it's a logical one. It's not random. Once you crack the code of the prefixes and suffixes, you can understand words you've never even seen before.
Okay.
It's like medical Lego bricks. You just snap them together to build the meaning.
I love that analogy. Okay, so let's unpack the blocks. We've got a few key prefixes that determine the speed or level of what we're measuring. First up, the speed toggles. Brady versus Toki.
Right. Simple concept, but huge implications. Brady always means slow.
Always slow.
Kakshi always means fast. You'll see these attached to almost everything.
And then we have the sort of directional ones, hypo and hyper.
Yep. Hypo is below normal or low. Hyper is above normal, high, excessive.
Yeah.
And then you have the negation prefixes, a or an, which means without, and dis, which means difficult or abnormal.
Okay, so those are the descriptors. Now we need the things they are describing, the roots,
Yeah.
the suffixes.
Exactly. So dynia refers to breath or breathing.
Got it.
Corticardia refers to the heart or pulse. Cardia is temperature. Tension is pressure, usually blood pressure. And pardypsia is oxygenation.
So let's play a quick round of put it together just to see how this works. If I see bradypnea on a patient's chart.
Okay, so brady is slow, nia is breathing. The patient is breathing too slowly.
Simple enough. And hypertension.
Hyper is high, tension is pressure, high blood pressure.
What about something like apnea?
A means without. Perdy is breath. So absence of breathing,
Which is not good.
which obviously is a major emergency.
See? It's not so scary when you break it down. It lets healthcare professionals communicate a really complex state in a single word.
Precisely. It's about precision and efficiency. In a code situation, you don't have time for full sentences.
Right. Patient is tachycardic, tells you so much more, so much faster than the patient's heart is beating really fast.
You got it. You need exact descriptions.
All right, let's move to the first actual vital sign on our list, the body's thermostat, temperature. Now, reading through the physiology notes here, it turns out we have a very specific control center for this.
We do. It's the hypothalamus, located deep in the brain.
The hypothalamus.
Yeah, think of the hypothalamus as the ultimate climate control system for your house. Its job is thermoregulation,
Thermoregulation.
balancing heat production against heat loss to keep the core stable.
And the notes list some fascinating mechanisms for how it does that. If we get too hot, the hypothalamus signals for vasodilation.
Right, opening up the blood vessels near the skin to let heat escape, and sweating.
And if we're too cold, it does the exact opposite. Vasoconstriction.
Clamping down those vessels to keep the warm blood near the vital organs. It triggers shivering, which generates heat through muscle movement, and it can even release epinephrine to boost metabolism.
Okay, this is where it gets really interesting for me, especially with that clinical judgment aspect we talked about, the normal temperature.
Right.
We all grow up hearing 98.6 degrees Fahrenheit is the magic number, but the NUR112 source material says, well, not quite.
It is definitely not a one-size-fits-all situation. This is where age variations are absolutely critical for a nurse to understand.
Yeah.
If you treat everyone like a healthy 30-year-old, you're going to miss things.
Let's look at the extremes. Newborns versus older adults.
Okay, so a newborn's range is typically 97.7 to 98.0 Fahrenheit. They're very, very sensitive to heat loss,
Yeah.
especially through their heads, which is why you always see those little hats on babies in the hospital.
Right.
But look at the older adults. This is the one that catches students off guard.
Yeah, the source says the normal range for an older adult drops to 95.0 to 97.0 degrees Fahrenheit. That is drastically lower than the average adult range of, what, 96.8 to 100.4?
It is. As we age, our metabolism slows down, we lose subcutaneous tissue, that natural insulation, and our vasomotor control just gets worse. We just run colder.
So what does this all mean practically? If I'm a nurse and I have an 85-year-old patient with a temperature of 99.0.
So to the untrained eye, 99.0 looks normal.
Right.
It's well below the standard fever threshold of 100.4.
Yeah, totally fine.
But for that elderly patient, whose baseline might be 96.0, a 99.0 is a significant elevation. That could be a raging infection.
Wow.
If you miss that because you're just looking at the textbook adult norm, you might miss sepsis.
That is a huge aha moment. Context is everything. Now, speaking of fevers, or pyrexia, using our new fancy vocabulary,
There you go.
the notes define a fever as anything greater than 100.4 F. But not all fevers behave the same way.
No, the pattern of the fever can give you clues about what's causing it. You have intermittent fevers, which return to normal at least once every 24 hours. Remittent fevers fluctuate, but they always stay high. Constant or sustained fevers just stay up there. And then you have relapsing fevers that disappear for a day or two and then come right back.
There is a very specific nursing intervention highlighted here in bold. It says, cultures before antibiotics. Why is the timing so critical there?
This is a golden rule of nursing.
Yeah.
A golden rule.
Okay.
When a patient has a fever, we assume there's an infection. We need to identify the bacteria so we know which antibiotic will kill it. To do that, we take a culture blood, urine, sputum, whatever. If you give the antibiotic first,
You mess up the test.
you start killing the bacteria before you've identified it.
Yeah.
You might mask the result, meaning the culture comes back negative even though the patient is sick. Then you're just flying blind, treating an unknown infection with a drug that might not even work.
So capture the suspect before you clean up the crime scene.
Exactly. Don't tamper with the evidence.
Moving on to the engine of the body, the pulse. The definition here is the rhythmic expansion of an artery. We've got stroke volume, cardiac output, getting into the hydraulics.
And just like temperature, the normal speed of that engine depends entirely on who is driving.
Right. Newborns have these racing little hearts, 85 to 190 beats per minute. That sounds terrifyingly fast to me.
It sounds crazy, but it's normal for them. Their metabolic rate is huge. Compare that to an adult where the standard range is 60 to 100. And even then, trained athletes might run lower, like 50, which is technically bradycardia, but for them, it's just healthy efficiency.
Now let's talk location. The notes list several sites to check a pulse. Radial, carotid, brachial, apical. Why do we need so many options? Why not just check the wrist every time?
Different tools for different jobs. The radial pulse at the wrist, that's your routine check. It's easy, it's accessible, and it's socially acceptable.
Sure.
But if you have an adult in cardiac arrest, you go for the carotid in the neck because it's a central artery. When blood pressure crashes, the body shunts blood to the brain and cuts off the limbs. So the wrist pulse disappears first.
And for infants?
Brachial, inside the upper arm. Their necks are just too short and chubby to find a carotid reliably, and their wrists are tiny.
Then there's the apical pulse. This involves actually using a stethoscope to listen to the heart itself on the chest wall. The source says this is the most accurate site. When do we need that level of accuracy?
You go apical when the radial pulse is weak, irregular, or if the reading is just outside normal limit. Also, if a patient is on certain cardiac medications, like digitalis, that affect the heart rate, you absolutely want to listen directly to the source. And you count for a full minute to be sure.
This leads to another fascinating concept mentioned in the slides, the the pulse deficit.
Yes.
The notes describe a scenario where you might have one nurse listening to the apical pulse and another feeling the radial pulse at the exact same time, and they get different numbers. How is that physically possible?
It seems impossible, right?
Yeah.
The heart beats, so you should feel a pulse. But think about the plumbing.
Okay.
If the heart contraction is weak, or if the blood vessels are blocked, the wave of blood might not be strong enough to make it all the way to the wrist. So the heart beeps, you hear it with the stethoscope, but you don't feel it at the radial artery.
So the apical rate is 90, but the radial rate is only, say, 70.
Exactly. That difference of 20 is the pulse deficit. It tells you that 20 beats per minute are essentially wasted. They're happening, but they are not perfusing to the extremities. That is a sign of significant vascular disease or a dysrhythmia like atrial fibrillation. It's a huge warning sign that the pump isn't doing its job efficiently.
That is wild. It's literally lost in translation between the heart and the hand. The notes also mention checking the quality of the pulse on a 0 to 4 scale.
Yes. 0 is absent, 2 is normal, 4 is bounding like it's trying to jump out of the skin. A 1 would be thready and weak. It just helps paint a more complete picture.
Okay, let's take a breath, pun intended, and look at respirations.
The third vital sign. This one is primarily controlled by the levels of carbon dioxide CO2 in your blood.
Not oxygen.
No, it's the CO2. When CO2 gets too high, the brain says, hey, breathe more to blow this off.
Again, we see the age factor.
Yeah.
Newborns are breathing 30 to 60 times a minute. Adults are much slower, 12 to 20. And here's where our terminology comes back. Bradypnea is less than 12. Tachypnea is greater than 20.
But here's the catch with respirations. The notes really emphasize that you can't just count. You have to assess the quality.
The quality.
Is it deep? Is it shallow? What is the effort? A patient might be breathing 18 times a minute, a normal rate. But if they're using every muscle in their neck and chest to do it, if they're gasping, that is respiratory distress. A number alone doesn't tell the whole story.
That connects perfectly to the next segment, the hydraulics. Blood pressure. This seems to be the one students struggle with the most.
It's definitely the most technical skill to master. You're measuring two pressures. Systolic is the top number. That's the pressure when the heart contracts and squeezes blood out.
The squeeze.
And diastolic is the bottom number, the pressure when the heart is resting and refilling.
And we are listening for those crock cough sounds. The first tapping sound is the systolic. And the moment the sound disappears, total silence. That's the diastolic.
Correct. Phase 1 and Phase 5, it really requires a trained ear.
But the biggest source of error listed in these notes isn't hearing the sounds, it's the equipment.
Yes.
Specifically cuff sizing. I feel like this is a massive exam question waiting to happen.
Oh, it absolutely is. And it's a critical error in real life.
Yeah.
The rule is that the cuff bladder must cover 2/3 of the adult arm, or the entire arm for a child.
What happens if you grab the wrong one? Say I use a regular adult cuff on a large football player.
Okay, so if the cuff is too small, it has to squeeze way tighter to compress the artery. This gives you a false high reading.
Ah.
You might think the patient has hypertension when they actually don't.
And if I use a large cuff on a very thin patient...
The opposite. If the cuff is too big, it obscures the pulse too easily, giving you a false low reading. You might withhold necessary medication because you think their pressure is too low.
So size matters a lot.
If you can't just grab the first cuff you see on the wall.
There are also some safety contraindications listed here. Places you should never take a blood pressure.
Right. This is all about doing no harm. You have to protect the patient's limbs. Never take a BP on an arm that has an IV line running, a dialysis fistula, or on the side of a mastectomy or lymph node removal.
Why the mastectomy side?
Because if lymph nodes were removed, that arm can't drain fluid effectively. Compressing it with a BP cuff can trigger lymphedema swelling that is painful and often permanent. You have to check the patient's history before you wrap that cuff.
We have 2 more signs that have been added to the classic 4, oxygen saturation and pain.
Yep. Oxygen saturation, or SpO2, measures how much oxygen your hemoglobin is carrying. We want that above 95%. It's non-invasive, usually just a little finger clip.
A quick check.
It's a great quick check on respiratory function.
And pain, the 6th vital sign.
This one is unique because it's completely subjective. You can't measure it with a machine. If the patient says their pain is a 7 out of 10, it's a 7 out of 10.
You believe them.
You believe them. But we still assess it alongside the physiological metrics because pain affects everything else. It raises the pulse, raises the BP, changes the respiratory rate. It's part of the holistic picture.
Okay, this brings us to the final, and I think arguably the most important part of our discussion, the so what. We have all these numbers, we have the definitions, but the notes have a specific section on nursing responsibility. And it asks a blunt question: can't a tech take these numbers?
And this is the crux of the nursing profession. The answer is yes, you can delegate the measurement of vital signs to a certified nursing assistant or a tech, provided the patient is stable. But, and this is a huge but, you cannot delegate the analysis.
So the tech can write down BP 150/90, but they aren't responsible for knowing what to do with that information.
Exactly. The nurse is responsible for looking at that number and asking, is this normal for this patient? What is their baseline? Are they in pain? Did they just run up the stairs? All of it.
There's a great example on the source text. A patient tells the nurse, look, yesterday my blood pressure jumped up to 50/90. I should be taking more medicine. And the multiple choice options for the nurse's response are very telling.
Right. The correct response isn't to just agree blindly or to dismiss it. It's to look at the pattern. The notes say the best response is, the doctor will first look at the pattern of your results.
Trends over time.
One isolated high reading might be stress or a full bladder or just a mistake, but a trend of rising BP over 3 shifts, that is a clinical problem. That is nursing. It's connecting the dots.
Right.
If you just look at snapshots, you miss the movie.
The notes also list when to measure vital signs: admission, beginning of shift, before and after surgery. But the one that stood out to me was reports of non-specific symptoms.
Yes. That's the I just don't feel right complaint.
Yeah.
Maybe the patient can't even describe it. They just feel off.
Yeah.
But their body knows. That's when you grab your kit, you check the vitals. You might find their oxygen has dropped or their pulse is racing. Listen to the patient, then verify with the data.
It seems like clinical judgment is really about integrating the subjective feeling with the objective number.
It is. It's about not being a robot. It's about recognizing that a machine can give you a number, but only a nurse can give that number meaning.
So, to recap our deep dive into NUR112 vital signs, it's not just about counting beats or reading a dial.
No. It's about understanding that a newborn is not a small adult. They run faster and hotter. It's about knowing that an older adult runs colder, so a normal temp might actually be a fever.
Right.
It's about knowing that a pulse deficit means the heart and wrist aren't talking to each other. And it's about ensuring your equipment like the BP cuff fits the patient, not just what was convenient to grab.
And ultimately, it's about ownership. You can delegate the task, but you own the interpretation.
Absolutely. The machine gives you data. The nurse turns that data into care.
I want to leave you with a thought to mull over as you head back to your studies or your next shift. We talked a lot about trusting the numbers, but also knowing the pitfalls of the equipment.
And here's the question I always pose. If you walk into a room and the monitor says the patient's heart rate is a perfect 80 and their oxygen is 99%, but the patient looks gray, is sweating, and clutching their chest, which do you trust? The sophisticated $30,000 machine or your own eyes?
I think we know the answer, but it's a terrifying moment to realize the machine might be lying.
Treat the patient, not the monitor. That is the first rule of clinical judgment.
Keeping your finger on the pulse of your education, pun absolutely intended. Thanks for listening to this deep dive into vital signs. We'll see you on the next one.
Stay curious.